All right. Good afternoon, everyone. Thank you for finding time and joining this meeting. Today, we will be talking about a particular type of patient that all of us encounter. And the reason why I thought we should have this discussion is essentially because s- you know I had an abnormally high number of consults over the last couple of months from our obstetrician colleagues, with regard to their patients who were pregnant and had low platelet count. Now, as always, this is going to be a practical discussion. I'm not going to go into details of, pathophysiology, etc. The talk would be focused more on practical approach and what should you do when you have a patient with such a problem. So, how many women actually have abnormalities in platelets during pregnancy is one of the first questions that come to our mind. And when we think of that, we have to also think of how do we define low platelets in pregnancy? Of course, we all are aware that there are a lot of physiological changes. Pregnancy is a physiological condition. To some degree, there is hemodilution, which may also bring down the hemoglobin a little bit. However, we need to understand that in pregnancy, the platelet counts remain above 150,000 per cubic millimeter, right? So they remain above 150,000. Hence, any woman whose platelets are below this level falls in the group of patients who have thrombocytopenia during pregnancy. How common is it? Depending on what kind of paper you read, which kind of data you access, but roughly about 5 to 10% of women will have low platelets during some phase of their pregnancy, which also means 90 to 95% will not, right? And whenever someone has low platelets, one of the first few differential diagnoses that we think of, especially in our part of the world, is either dengue syndrome, dengue-like viral fever, or we immediately start thinking of ITP. And we start thinking, okay, this must be ITP. The dengue tests are negative. I'm going to start steroids. That might not be the right thing to do because within if you look at all the pregnancies, ITP is only seen in about less than 0.1%. Hence, if you have a pregnant lady with low platelets, do not have a knee-jerk diagnosis of ITP and say, hey, I'm going to give you steroids, right? The other question that comes to us is what actually happens? The platelets are low, we have to do something. What if there is bleeding? So let me give you a few numbers which will help you prioritize your patients. So somebody whose platelets are very low, right? Even less than 20,000, they can safely go through a vaginal delivery. Uh, Remember, these are guidelines and you have to look at every patient individually. But even with very low platelet counts, a normal unassisted vaginal delivery can be conducted, right, up to if the platelets are more than 20,000, and only when they go below 20,000 should you really worry about bleeding, right? If you are going to do a cesarean section, then you should worry if the platelets are below 50,000. And if you or your anesthesia colleagues want to give neuraxial anesthesia, epidural anesthesia, analgesia, then you need to try and keep the platelets above 80,000. So vaginal delivery, platelets above 20,000 are good enough. Cesarean above 50,000 and neuraxial anesthesia above 80,000. So, with this kind of a overview as to in how many women platelets can be low, what percentage, the fact that ITP is very rare in pregnancy, and these are the platelet counts that we need to watch for. Having said that, we also need to understand what are the broader implications of thrombocytopenia in pregnancy. How could we deliver the patient, the lady? Should we do a vaginal delivery? Is LACS okay? Well, that depends on the obstetrical consideration. As far as hematology and platelet counts are concerned, we have no preference towards any particular mode of delivery, and we leave it completely to our obstetrician friends, saying, hey, look, if you want to go ahead and do LSCS, go ahead, let me see how I can optimize the platelet count so that whatever it is that you want to do can be done safely. The risk of severe hemorrhagic complications is truly very low, right? As long as we maintain those 20,000, 50,000 kind of levels, you don't need 150,000 normal platelet count, right? Because the risk of bleeding is pretty low. One thing, however, is there is we recommend that they avoid any kind of assisted vaginal delivery. So avoid forceps, avoid vacuum assisted vaginal delivery. The reason is if the mother has low platelet count, it's possible that the baby also has low platelet counts. And if we use any kind of instrumentation, then the baby has a risk of intracranial hemorrhage. So it's to protect the child that we say do not use or rather avoid using forceps or a vacuum. Go ahead if possible with normal vaginal delivery. If you need, go ahead with LSCS. What about neonates? Of course, I told you, we avoid instrumentation. And when the baby is born, we should collect a cord blood sample for platelet count just to see what's actually happening. What is the baby's platelet count? This is particularly important in ITP, those rare cases of ITP, because the mother's antibodies against platelets. The mother has antibodies against platelets, and these could cross the placenta and affect the fetus, thus decreasing the fetal platelet count. So, at birth, please take a cord blood sample for complete blood count, check the platelet count. However, keep in mind that very rarely would the neonatal platelet count will be low. So by low, I mean, less than 20,000. It's only 1 to 5% of neonates are born with exceptionally low platelet counts. If the platelet counts are low, consider the neonate to be a separate patient and evaluate the neonate thoroughly for all kinds of causes of thrombocytopenia. Do not assume that if the mother has something, the baby would also have a similar problem. What is also important is life-threatening bleeding or a bleeding, serious bleeding, which could cause morbidity, such as intracranial hemorrhage, is very low. Less than 1% of neonates have this if their mother is also having low platelet count. So generally speaking, neonates are safe. However, you should do a cord blood count at birth, and if there is any clinical neurologic impairment in the neonate, then do an ultrasound of the brain to see if there is any intracranial hemorrhage. Now, with this kind of a very broad overview, let us see what we should actually do when we have a patient like this, when a lady checks into an ANC clinic or into a labor room for delivery. First of all, we need to understand, is the platelet count really low, or is this a false low, pseudo-thrombocytopenia? Uh, why do we say that? There are three reasons, and on this slide, I'm only going to put two. But the third reason is equally important, and all of us are aware. Remember, wherever we do our blood tests, not every lab does good quality control. So wherever you are sending your full blood count, the lab should be running regular quality controls, doing regular servicing of their automated cell counter. Now, let's assume that we are sending the samples to a good lab, a quality conscious lab, and the platelets are still low. We still have to look at two more causes of false low platelet counts, pseudothrombocytopenia. First one is giant platelet syndrome. This is especially important for us in India because these are patients whose whose platelets are larger since birth. It's like, some people are tall and some people are short. Similarly, a small number of people have very large platelets. Now, if you look at this peripheral smear, you see these tiny specks. These are normal platelets. All right, that's the normal size of a normal platelet. What happens in giant platelet syndrome is look how big they have become. And these giant platelets are larger than the normal size. So the normal MPV, mean platelet volume, is 4 to 11 femtoliters. These individuals, the mean size, the mean volume of the platelets is usually about 14 or 15 or 16. So really large, platelets. Now, what happens with these large platelets is we get a false low platelet count. And why does that happen? That happens because our automated cell counters obviously work on a software. They work on a software. What the automated cell counter, your Coulter cell counter, does is it measures the number of cells and the size of cells. And the software says that if the size of a cell is between this much and this much, it must be an RBC. Count it as an RBC. And if the size is between this much and this much, count it as a WBC. And the smallest cell, if the size is between 4 to 11 femtoliter, then the software says count it as a platelet, right? So all of these tiny specks would be counted as platelets. But the giant platelet, which is a normal platelet, right? It's just that this individual, some patients, they're not even patients, some normal people have larger platelets. This larger platelet does not fall within this range, within that software parameter. Hence, they are not counted. The machine thinks it's too large. It's not an RBC. It's not a WBC. It's not a platelet. It must be a dust particle. Ignore it. Don't count it. Hence, what will happen is uh, the the individual may have 150,000 or even 400,000 platelets. But if half of them are large, the report will only say 200,000. Or if the individual has 150,000, the report may say 75,000, right? It may give you a false low because half of the platelets will not be counted. This is seen in about 1% of normal individuals. Remember, this is not a problem. And in East and Southeast, East and Northeast India, up to one third of the population in some parts may have large platelets. And it's just inherited. It has something to do with the platelet cell membrane. Again, I'm not going to go into the details of this. And because different machines have different softwares, the patient will often tell us, doctor, when I in one lab, my platelet count came as 75,000. In another lab, they said 105,000. I don't know what's happening. It's because the softwares in different machines are a bit different. Hence, it gives varying platelet counts. So that's the first important cause of pseudothrombocytopenia. What about the second? The second important is what we call as platelet clumps. Now, you see, when we send a sample, when we order for a complete blood count or a full blood count, as it is called in some parts of the world, the blood is collected in a EDTA tube. EDTA is the anticoagulant. It's supposed to prevent that blood from clotting. It keeps the blood in a liquid state. However, in some people, this EDTA, which is supposed to be an anticoagulant, will activate the platelets. It will activate. Remember, it's not clotting, it is activated, and the platelets are activated, and then they start sticking to each other and they create a platelet clump. This is not a clot, these are just platelets sticking to each other, platelet clump. Again, because this is so large, the machine is going to ignore it. There is no way your automated cell counter can count individual platelets in this clump. And hence, all of these will not be counted and you'll get a false low platelet count, right? How do we get around it? Well, don't send the sample in EDTA. Collect the sample in a sodium heparin or, your PTA tube, that's a citrate tube, or take a direct finger prick on a slide, smear the slide and do a manual platelet count, right? So it's very simple. The way to differentiate real versus false low platelet counts is a manual platelet count. Manually, when our pathology friends look under the microscope, they can say, hey, there are giant platelets. Along with the small ones, they'll also count the larger platelets, or they will say, hey, your patient has platelet clumps, and I'm giving you a proper manual platelet count. So, this is step one whenever you get a patient with low platelets. I said in the first slide that platelets less than 150,000 are considered to be low in pregnancy. However, there are many patients or many women whose platelets will be between 100,000 to 150,000. So they have mild thrombocytopenia. And in these women, you may choose, no, it's very mild. Platelets are more than 100,000. I don't want to do a complete evaluation. I don't want to do a bone marrow exam and all that. Sure, that's fine. However, if the lady's platelets drop below 100,000, you have to do a proper evaluation. You have to look at the differential diagnosis. How do you do that? Like I said, step one, do a manual platelet count, do a peripheral smear, ensure that there is genuine thrombocytopenia. And then we start thinking of what are the causes of low platelets in pregnancy. Now, I divide, the cause of a low platelet count in pregnancy in three buckets. Okay, that's how I look at it. So first is, all of us know gestational thrombocytopenia. Everyone knows that during pregnancy, the platelets may drop a bit and they recover once the delivery is done. Very rapidly they recover. Second bucket are the complications of pregnancy. There are several conditions which occur specifically during pregnancy which can drop the platelet count. That's the second bucket. And the third bucket are primary marrow disorders, primary hematologic disorders. So this is how, once I've confirmed genuinely low platelet counts, I start thinking, all right, is this GT? Is this some pregnancy associated complication, or is this a primary hematologic problem, primary marrow disorder, so to say? How do we differentiate? GT, gestational thrombocytopenia, platelet counts are generally not very low. They are not very low. Okay. So platelets remain more than 70,000. It's kind of mild to moderate thrombocytopenia. It does not drop below 70,000. That's what we should remember. It happens in the later stages of pregnancy. So if you get a patient in the first trimester, in the first month, or second month of pregnancy with platelets of less than 100,000, no, it's not GT. GT starts and presents generally in the second and third trimester. On incidental, by chance you have done a complete blood count and you see mildly low platelets, usually more than 70,000. They do not have bleeding. Once the delivery is done, postpartum, the platelets will spontaneously recover. You don't have to give steroids, you don't have to give platelet transfusion, nothing. So this is mild thrombocytopenia, more than 70,000 platelets usually, occurs later in pregnancy and spontaneously recovers and can come back in subsequent pregnancies where we can see the same pattern. Typically, when we see a lady who has GT, gestational thrombocytopenia, she'll tell us, yeah, doctor, even last pregnancy, my platelets went down. Then we ask her, okay, how low? What was the lowest? And she'll say, 80, 90,000, doctor, nothing much. I had a delivery. And did you require any platelet transfusion? No, 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 doctor, nothing. And, they did a delivery. And then after delivery, I checked two, three times, my platelets came out to be normal. That's classic gestational thrombocytopenia, right? Second bucket, pregnancy associated conditions where the platelets may drop, right? These are not primary marrow disorders. HELP syndrome, we all know this. It's a serious complication. Liver enzymes are elevated. There's thrombocytopenia as well, typically associated with eclampsia, preeclampsia. Acute fatty liver of pregnancy, we really don't know the pathology, the pathophysiology the etiology of this condition. But in acute fatty liver of pregnancy, platelets may drop. DIC, If the patient has any kind of major infection, so puerperal sepsis, right? DIC due to intrauterine death, then because of infection, which is serious, it can trigger coagulation inside the body. Normally, the blood flows as a liquid across the pipes, the arteries, veins, and capillaries in our body. But the tiny vessels, especially capillaries and arterioles and venules, if they start having tiny clots, disseminated intravascular coagulation. So clots, microthrombi are formed, fibrin strands, that is, clotting happens and the platelets get consumed. So this is consumptive coagulopathy. DIC, very well-known complication of pregnancy, right? We've all seen this. Then pregnancy may be associated with HUS/TTP. We all know HUS is hemolytic uremic syndrome, and sometimes it presents more as microangiopathic hemolytic anemia or breakdown of platelets inside the vessels, which is called as thrombotic thrombocytopenic purpura, HUS-TTP. HUS-TTP is also associated with pregnancy, and that can lead to low platelet count. So, what is kind of the spread? What's the incidence of these various disorders? If you see, 76% of patients who have, or 76% of women who have low platelets during pregnancy are going to have gestational thrombocytopenia. Again, before you label them as GT, they have to fulfill these criteria. If they're having low platelets, less than 70,000, don't label them as GT. 20% would be preeclampsia, and preeclampsia, eclampsia associated complications such as HELP syndrome. And about 1% of patients, 1 to 3% of patients would have a marrow problem or an ITP. Now, this 3% is among the patients who have low platelets, 3% would have ITP. Okay. But if you look at all the pregnancies, ITP happens in less than 0.1%. So now we come to the third bucket, that is the primary marrow disorders, hematologic issues, which could cause low platelets in pregnancy, and it can be autoimmune, that's ITP, right? Like I said, about 3% of all women with low platelets in pregnancy will have ITP. It could just be that the marrow has failed. Do not forget these conditions which may be there. Do not label patients as just GT or HELP syndrome associated. It could very well be aplastic anemia or abnormal cells packing the bone marrow and not allowing normal platelet production, as in leukemia or lymphoma, right? So the factory may be empty, as in aplastic anemia, or the factory, that is a marrow, may be packed with bad cells, cancer cells, such as leukemia, lymphoma. So these are the three broad buckets. Okay. So you understand the three broad buckets, you understand when to evaluate, you understand, whom to evaluate completely. If platelets are less than 100,000, you need to evaluate the patient. You don't need to do bone marrow exam for everyone. So whom should we evaluate, to what extent? Let's see. So you have a patient whose platelets are less than normal, less than 150,000, right? You're going to do a peripheral smear. You're going to ask your pathology colleagues to do a manual platelet count and tell you that, all right, this is genuine thrombocytopenia. Now, if the platelets are still over 100,000, sure, you can wait and watch and repeat after 1 week or even 3-4 days. But if the platelets are already below 100,000, you have to start evaluation. And these are the basic things that you need to do for any lady whose platelets are less than 100,000. So you're obviously going to check the blood pressure. You want to look for preeclampsia, eclampsia. You're going to do a proper complete blood count, look at the white blood cells, ask your pathologist, are there any abnormal cells on peripheral smear? Is this a leukemia, right? Any atypical cells? Are there any schistocytes which are seen in TTP? Okay. You will do a dengue test, you will do IgG, IgM, and NS1. You will do a malaria test. There are various malaria tests available depending on what is available to you. You will look at the liver, you will look at the kidney, because kidney can be affected in HUSTTP. And you will do LDH. LDH is high in vitamin B12 deficiency, right? LDH is high in vitamin B12 deficiency. LDH is high in HUSTTP, specifically TTP, and LDH is high in leukemias or lymphomas. So, blood pressure, complete blood count, peripheral smear, do basic dengue malaria test, look at the liver, kidney, and do LDH. And look at the coagulation, look at PTAPTT. Now, here I would like to make one very, very important, statement. Until now, whenever we look at coagulation, people will say, yeah, I have done BTCT. I have done bleeding time and clotting time. Bleeding time is still a good test. Please do it. It tells us about platelet function. But if somebody's platelets are already low, 10,000, the bleeding time is going to be prolonged. CT, clotting time, is a test which is outdated. It has been abandoned, and the CT clotting time has been replaced by PTAPTT. So what we need to do when we look at coagulation is platelet count, bleeding time, PTAPTT. Stop doing clotting time. It is not accurate. It's very insensitive, right? So these are the basic things that you will do, primarily blood tests, right? And after this, you will see that, okay, WBCs are fine. The WBC differential is okay. Peripheral smear is not showing cystocytes. It is not showing malaria parasite. It is not showing any atypical cells, which could make you suspect leukemia. So you see, very basic evaluation, okay? And at this point, you then decide, okay, what to do. Every now and then you'll have a patient where your pathology friend will say, no, 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 there are schistocytes, okay? Then you have to ask, okay, how many? How many? Remember, schistocytes means broken RBCs. Broken RBC means schistocyte. So you take my blood, you put it on a glass slide, and you smear it. During smearing, some RBCs will break. During smearing, some RBCs will break. And every slide will have some schistocytes. However, what we need to ask our pathology friends, does the slide have more than 1% cystocytes? Means amongst all the RBCs, can you count and tell me what percentage of RBCs are broken? So if they have more than 1% RBCs, if you're seeing any neurologic features, and neurologic features may be very subtle, they may just be drowsiness, they may be confusion, it may be seizures, right? So any neurologic feature, more than 1% schistocytes, you're going to think, all right, maybe this is HUSTTP. Okay. And here you have to confirm, you have to urgently send Adam TS13 level. I know most of you will say, hey, that's too expensive, or I don't have access to it. I agree. Now, if you have your pathology says, no, the entire slide is full of schistocytes, then it is TTP. But the diagnostic test is an Adam TS13 level. Most of the referral laboratories in most of the countries today provide this. If possible, please send. Urgently get an urgent report, because in HUSTTP, you have to urgently start plasma exchange. You have to start plasma exchange. You have to involve a hematologist, you have to involve a nephrologist, dialysis team, and start plasma exchange. This is the only thing that works. And I, had a patient about 4 or 5 months ago, and she was in the third trimester and did not have major neurologic features. Schistocytes were not very great on peripheral smear as reported by our lab. Ferritin was very high, and I thought maybe this is hemophagocytosis. And I delayed this testing and I delayed plasma exchange. Right? That's not good. If you do the Adam TS13 level and quickly start plasma exchange within 1 to 2 days, you're going to save this mother. Okay. The second type of patient where your pathologist says WBC total differential is normal, peripheral smear not showing cystocytes, not showing any leukemic cells, atypical cells. What do you want to do next? Then you say, all right, how low is the platelet count? All of these things are negative, and if the platelet counts are not very low, they're 85,000, 90,000, you don't have to aggressively evaluate. Okay, you have to start thinking, however, you're measuring the blood pressure, you're checking the LFT, the liver function test for HELLP syndrome and acute fatty liver of pregnancy. You have done PT-ability for DIC. If it is not fitting in and the platelet count is not very low, yeah, more than 100,000, but more than 70,000, right? So if any one of these conditions are there, sure, treat accordingly. If not, even this is negative, all of this is negative, platelets are not very low, you may say, all right, I'm just going to monitor closely. Okay. And by closely, once a week, once in 2 weeks, you repeat the complete blood count, and the platelet stays above 70,000 throughout pregnancy and intrapartum and postpartum, the platelets improve. Postpartum, you make a diagnosis of gestational thrombocytopenia. So GT is not an early diagnosis. The diagnosis has to be made after delivery if the platelets recover spontaneously. Okay, it's a postpartum diagnosis. However, if as you're monitoring this patient, the platelets start dropping to 60,000, 65,000, 50,000, 40,000. Now this is not GT. Remember, in GT, gestational thrombocytopenia, platelets are generally more than 70,000. If it starts dropping below this, do a marrow. Look at the factory. Is the factory empty? Is the factory having bad cancer cells? Or is the factory normal, which means ITP? It's an autoimmune problem. Do a ferritin to rule out hemophagocytosis. Look for Apla syndrome. Okay, now this is a serious patient. They're going to get sick. Platelets are really dropping. Okay. What if in the beginning itself, the platelets are low? Beginning itself, the platelets are low. But all of these things are coming as normal. Do a marrow early. Anybody with less than 70,000 platelet count, first trimester, second trimester, third trimester. I have done marrows immediately before delivery also. I have done marrows in the operation theater because the platelet count was very low, and our obstetrician says, hey, I want to take up for LACS. I said, great, let's take for LACS. I'll come in the OT and I'll do a bone marrow exam. But when the platelets are low, remember, you have to do the bone marrow exam early. You don't want to miss an aplastic or leukemia, right? You're going to do an APLA test as well. And when these are not normal, okay, when your pathology says, no, the WBC is high or low, or I'm seeing some atypical cells, maybe leukemia, I'm not sure, or there is pancytopenia, RBC, WBC, platelets, everything are low. No, this is not GT. This is not HELLP syndrome. You have to do a marrow early, again, to rule out those conditions. So this is the algorithm which I've kind of figured out from various consensus guidelines, and this is how I approach pregnant women with low platelets, right? Now, after all of this, you've done a marrow and marrow is normal, and you think it's an ITP, you've diagnosed it, and sure, and then you go ahead and you give steroids. But without doing a marrow, without doing proper evaluation, don't assume ITP. I told you less than 0.1% of pregnant women have ITP. Do not give steroids, because without a proper evaluation, if you assume ITP and if you give steroids, then the steroids may mask the diagnosis of leukemia. Remember, steroids are an important part of leukemia chemotherapy, especially lymphocytic, ALL, and also lymphomas. So if you just give steroids without a proper diagnosis, without marrow exam, then you may end up missing a leukemia, which is going to be disastrous. However, if the lady is near term and you're worried, your obstetrician is worried that she may have a early induction of labor or about to go into labor, but it's preterm, and if your obstetrician says, no, I want to give steroids for fetal lung maturation, go ahead. No problem. That's fine. Okay. But do not assume ITP and treat like ITP with steroids. Okay. Fetal lung maturation steroids, sure, no problem. How do you treat ITP in pregnancy? So now I'm assuming that you've ruled out HUS TTP, HELP syndrome, acute fatty liver, blah blah blah, leukemia. You have done the marrow, and now you've made a diagnosis of ITP. And now the pathologist says, "Hey, Sachin, what do you want to do? Now that you've done everything, including a marrow exam, how are you going to treat my patients? How do I do the delivery?" Well, this is how we treat. Okay. And not just ITP, I'll tell you all of these. So, all the three buckets: gestational thrombocytopenia, pregnancy associated conditions, marrow disorders. GT, platelets, I told you more than 70,000. You don't have to do anything. The lady could even go through an LSCS, nothing happens, right? No specific treatment is required. Platelet transfusions are not required. Uh, and postpartum, you have to document that the platelets recover in the next couple of weeks. And at the next pregnancy, you have to be aware that the platelets may again drop. Okay. What about other conditions, pregnancy associated conditions with low platelets? How are you going to manage during pregnancy? Well, you have to treat the primary problem. And most of these conditions, again, the platelets may not be very low. But however, if the platelets do drop below 50,000, check PT-APTT, because to prevent bleeding, you have to not only give platelet count, platelet transfusions, but if the PT-APTT is prolonged, you may also have to give fresh frozen plasma, because you have to give the coagulation proteins along with the platelet to cause good clotting, to prevent intrapartum, postpartum hemorrhage. Okay, so if the platelets are very low, whatever is the condition, do check PT-ability, ensure you optimize the entire coagulation cascade, and also keep platelets ready. You may have to give platelet transfusion to these patients if the platelets are dropping. Start intrapartum, just before the delivery, continue intrapartum, continue monitoring after delivery, ensure that platelets are safe, right? What about primary marrow disorders? Aplastic anemia, leukemia, etc. is a different ball game altogether. When we have such serious diagnosis being picked up in the marrow, the priority is saving the pregnant lady's life. It takes a lot of effort and repeated discussion, counseling with the obstetric team, with the family, with the mother, right, with the pregnant woman, to say, hey, look, we strongly recommend medical termination of pregnancy. And we had a patient like this a few months ago, who, if I'm not mistaken, was 25 or 26 weeks pregnant, and legally, medical termination of pregnancy in India can be done up to 20 weeks, right? So this lady had crossed it. So as per law, we had to follow protocol. We had to get two doctors, two gynecologists, two obstetrician, to say, yes, if the pregnancy is continued, it will be a serious risk to life for the lady. And hence, we go through multiple discussions. And if the woman agrees, then we try to induce labor and do medical termination of pregnancy, even if it is very late. Of course, if the pregnancy is near term, the lady is going to deliver in a week or so, then you're going to try and manage the marrow problem, give blood transfusions, platelet transfusions, antibiotics if there is infection, and try to have as safe a delivery as possible, because near term you're not going to induce labor. Near term, you're not going to look at medical termination of pregnancy, right? So you're going to try and keep the mother safe, and sometimes you may be able to deliver a healthy baby, and then manage the primary marrow issue, right? If the pregnancy is near term. If not, strongly recommend medical termination. Save the woman's life, and tell, hey, maybe you could try to get pregnant later, but right now it's your life that bothers us. What about ITP? How do we manage ITP in pregnancy? All right, so you've ruled out other things. Marrow is also okay. And you say, hey, this is immune thrombocytopenic purpura. and you've confirmed it, then what I ask the obstetrics team is, when do you think she will deliver, right? If she's in third trimester and they say, no, doc, she's near term, I think in a couple of days I'm going to induce her if the labor does not start spontaneously. So delivery is imminent in a very, very short time. At that point, what I will do is, of course, they would want to give steroids for fetal lung maturation. That's fine. For the mother, I'm going to start high dose steroids. High dose dexamethasone, 40 milligram, oral or IV, once a day for 4 days. This brings up the platelet count in about 4 to 5 days. Median is 6, 7 days, right? So this will quickly bring up the platelet count. If you want the fastest increment in platelet count, give immunoglobulin, IVIG. Okay, give IVIG 0.4 grams per kg. One dose is enough. Anything more than that, there is enough data to show that it's not required. This will typically bring up the platelets in 2 or 3 days maximum. So you can try IVIG, try high dose DEXA. It brings up the platelets very rapidly up. You can also give two drugs. There are two medicines available, eltrombopag and romiplastim. Okay, romiplastim and eltrombopag. Eltrombopag is a tablet, romiplastim is an injection. These are thrombopoietin analogs, thrombopoietin. So these are like, what erythropoietin does for hemoglobin. You give erythropoietin, it will stimulate the marrow to make more hemoglobin. Similarly, you give thrombopoietin analog, it will stimulate the marrow to make more platelets. So you can also give romiplastim and eltrombopag. That's the dose, but this takes some time to work. It takes 1 or 2 weeks to work. Until then, you have DEXA and IVIG. Keep platelets ready. Okay. Even if after dexamethasone or IVIG, your platelets have started improving, they may again drop in a week. Okay. So for the delivery, you have to keep either 8 random donor platelets or at least one single donor platelet, and both are equal. There's no difference between 8 RDPs or one SDP for adults. So keep these ready because the platelets may drop just before delivery. They may go up and come down. Send PTA/BTT, ensure you have given FFP, give all the coagulation factors through fresh flows and plasma. Keep packed red blood cells ready. If there is bleeding, you may need to transfuse. So this is how you prepare for a imminent delivery. How do you actually conduct the labor? If possible, do a planned induction of labor, right? So that you have things under control. This is third trimester, very close to labor, delivery time, and if the EDT is right up there, talk to the family, talk to the obstetrician, try to have planned induction of labor, prefer vaginal delivery. If it's required for obstetric indications, no problem, they can go ahead with LSCS. We are trying to keep things ready, right? Avoid forceps or vacuum, as I had said earlier. If the platelets are low, you remember that 20,000, 50,000. So vaginal delivery platelets, we try to keep it about 20,000, LSCS above 50,000. So if platelets are below that level, start platelet transfusions before delivery, continue intrapartum. Okay. And that's kind of, these are the rule of thumb numbers. Yeah. For what should be the target platelet count. Once the delivery is conducted, like I said earlier, check the cord blood, complete blood count, check the child for clinically for intracranial bleeding, and monitor the child's CBC for about 3 to 4 days every day to ensure. Sometimes, their platelets may drop a bit later. What about the mother? Postpartum, post-discharge, monitor CBC frequently until it's stable at more than 30,000. By frequently, once in 3, 4 days, and then slowly once a week, and then once a month. Uh, Now that she has delivered, give proper treatment for ITP. So you can give steroids, eltrombopag, romiplastim, azathioprine, rituximab, whatever it is that, your physician or hematologist prefers for treatment of ITP. What if it is early in pregnancy? What if you've diagnosed ITP in the first trimester, second trimester, or early third trimester, right? So delivery is not going to happen very soon. And now I have time. Now I have time to try these things and bring up the platelets and stabilize them. Bring up the platelets about 20,000 and stabilize them before the delivery. So I'll try again the same drugs, high dose DEXA, IV immunoglobulin. I'll see what works, because high dose DEXA does not work in 20% of patients. In only 80% will it work. So, but I have time now. Pregnancy is not imminent. So I'll give high dose DEXA, I'll give IV immunoglobulin. I'll see what will bring the platelet count about 20,000, 30,000, 50,000. I could try romiplostim, eltrombopag. There are other drugs which have been tried. But remember, azathioprine, cyclosporin, these are only known as case reports. They are not legally, technically, they are not considered to be safe in pregnancy, right? But in an emergency when nothing available, well, you could try these. So it's early in pregnancy. I have time to treat and figure out what is working for a particular woman, and then prepare her, keep her, stable for a delivery. So that's about it. And as always, I'm doing talks like this because although we have built multiple departments, we know that majority of the patients are in the community with all of you, with physicians, pediatrician, and obstetric colleagues. And it's our endeavor to help you in your practice, and to so that you are able to make informed decisions. And of course, at any point in time you need any help, feel free to call me. I don't follow WhatsApp very much. So if you want to discuss a patient, just call directly. And I'll be uploading this talk on YouTube, and that's the YouTube handle. Thank you so much. I'll be happy to take questions now. I would suggest that you put your questions in the chat box so that I could read them off and answer. Yeah. Any questions? All right. So what I will do is I will end today's session and upload this video. And of course, if you have questions, please feel free to send them to me on WhatsApp or email. Thank you so much for your time. Bye. Take care.